always, I'm very happy to be here and talking to you about things that I've been working on for a very long time. So today I want to tell you about when we do any analysis of the data, there are 3 questions that we always ask ourselves. Actually, there are 4, but we're going to address 3 of them. And I'm going to talk about those 3 questions that always bother us when we do analysis of the data. And then talk about what the kind of solution would be. And here is to go and leverage public domain data sources, right? And may not be the first thing we think of, or that we think we should be thinking of, but we don't always think of, right? And then we'll give some examples. So, you know, a data source is not very interesting by itself. It is what it can do, which is interesting, right? I mean, few people are interested in a bee by itself, but most people are interested in the honey, right? So it's more kind of the usage of the data that drives interest in the data, but not the data per se. So we'll give examples of business questions we ask, and so we have three sections there, and Shanmugam is going to help us with the enhancement, which is a big one here, and then we'll recap the what I call the hidden gems, and we chose the number 26 because of the 26 letters of the alphabet. Right? So you remember 26. Okay, so the 3 haunting questions that we have when we do data analysis. The first one is, how complete is the data? So when you look at the data, we have the numerator. So the data tells you what's in there. But the piece that we don't have is what's not in the data, right? So that's the question about, let's call it the denominator, or what's missing, or the holes in the data, right? This is something that we have to grapple with. The second question is, the data that we have may not be at the granularity that we want. So we may have, say, state level, but we want to have subnational, for example, at the physician level. If we have the physician, maybe we want it to be at the patient level. So we always want added granularity, so basically enhancing or linking the data with something else. And the third question that we have when we get frustrated a little bit is there some other data sources that would help us better with the one that we're using, right? So I'll call them the CEN, right? The completeness question, what are we missing in the data? The enhancement question, can we increase the granularity of the data? And the new perspective, is there something brand new that we're not looking at? Okay, make sense? And so the approach that we're suggesting here is to use public domain data, right? And when you, by and large, when you talk with people, you want to be able to use free data sources that are trustworthy, powerful, that you can rely on, and leverage those data sources. But interestingly, when you talk with people, many people don't seem to know about those data sources, right? And so I have a little cartoon here, and the lady says, oh, there's a bunch of free data sources out there, and what do you think about those data sources? And the answer is, what data sources, right? And it's interesting that you get that response from people. And you know what's kind of interesting is that those data sources are free. And if you come from Econ 101 would suggest that, you know, if the price goes really down, then we should be really aware of those data sources, right? So it seems to me like a paradox that the data source is free and still we don't use them. And the reason we don't use them is because we don't know about them. And why don't we know about something that's free? For 2 reasons. Number one, there's no dog and pony show. Right? No one is getting paid to push the data to you. So no one's calling you, hey, we have to have a meeting and show you how great the data, sing the praises of the data. That's not happening. And also, if you happen to be using the data and you have questions on the data, there's no one to answer your questions, right? So because of those 2 major reasons, we have the paradox of the free, which means that by and large, people do not know the existence of those data sources, which is a little sad, right? Because it's free and we don't use them. You're good? Okay, so what we'll do here, let's unveil the secrets of the gems. And it's good the room is very small here, so the secret's only for you. Okay. So how we discovered that, and it's a very long journey, right? I've been in the business for a long time, and we have always had an interest to go and uncover different data sources. And we spend time regularly talking with data vendors on behalf of our clients and sometimes on our own behalf to understand data sources that are there. Because I think that's the key to any good analysis, to kind of know the data landscape. And by the way, I also teach classes on data sources and so on. So let's start with completeness, right? So that's the question about, you have the data and what is not in the data. You want to have an idea of what's missing, right? That's a question we always have. So let's call it the dynamic question. So an example, PLD, patient level data, is sample data. It's not projected like experiment, right? And it has many hosts. And as we know, there are 3 different feeds in the PLD. One is NCPDP, which is the RX piece, right? The pharmacy pod. We have the CMS 1500, which is the physician office sending the claims and the lab and all that stuff, right? And the third one is the hospital, and that's known as the UBO4, right? Universal Bill 2004. And by and large, across different therapeutic areas, the capture rate on the NCPDP is pretty good, 90%. The CMS about 45%, 45%, and the hospital a dismal 15%, right? So there are holes in there, and you want to know how much is not captured, and that varies quite a bit depending on the TA, obviously, right? That's kind of general stats. And so what can we do? We know the holes, and how is there a way for us to kind of gauge the size of the holes? So if you look at the kind of evolution in terms of treatment, you have people before they get sick, and then the people, like let's call it incidence prevalence, right? People get the disease. And there's a difference between having the disease and being diagnosed with the disease, because you need to go to see a doctor, or go to the hospital or something, right? Then you get the diagnosed, and then you get treated, right? So you have the funnel, typical epi funnel that you see here. And I'm going to say a few words about the people, right? And then about the prevalence. And so let's take a fun place where a lot of things are happening, which is in the cancer space, right? And then I'll say a few words about the treated and the state Medicaid. State Medicaid is interesting because a few years ago, if you wanted to get state Medicaid data, you had to go to individual state, and at the time, if I remember correctly, there would be something like 8 states where you cannot get the data. And today we get the data on all 50 states, one-stop shop, right? So this kind of good news. So let's go to the US American Community Survey. So it is basically detailed socioeconomic data on the population and housing, right? You have multiple levels of geography. So starting at the nation level, right? So this is the whole US. It goes down at the state, and then it goes at the county. There's about 3,142 counties in the country. And then it would go to places a mix of cities, towns, villages, and so on. And then you have something called the zip code tabulation area. You're familiar with that? It's almost like the zip code, but it's less like it's more, I would say, solid in the sense that it changed less with the postal office, right? So some zip codes do not have a CTCA, so it's kind of more interesting in terms of tracking behavior as opposed to posting it and that kind of stuff, right? But for practical purposes, you can kind of take them to be synonymous. And then it goes down to MSA, and then census tract. There's about 50,000 census tracts in the country, right? It goes below that to the block groups, about 200,000 block groups, and even below to the actual block, which is about 11.1 million blocks in the country, right? So this is pretty cool because you have data, social data, economic data, housing, and demographics, right? And let me give you an example here. So there are 56 variables, right? So starting with population by sex, the age, median age, and it goes on like this, poverty, and so on. And this is absolutely free, right? So the reason you're not using it is your ignorance, right? Which is interesting. Yeah. So if we just kind of give you a sense of what, if you go there and play with it, what you'll find. If you look at the private health insurance, this is the kind of data you'll get. So we prepared a little table here. You can see people with private insurance, without private insurance, broken by male, female, broken out by age, that kind of stuff. And this is just for one county. And we have this for more than 3,000 counties. Absolutely free, right? So this is a cool data source. If you go, yeah, you're good on this, on the US Census. US Census is not only population, right? If this is kind of what you thought about, that's not true, right? You have 56 variables. So think of a pack of cards with 4 jokers, 2 jokers, 4 jokers, right? So you get 56 variables there. Yeah, you're good? Any questions, comments there? Another one that you can look at, which is interesting, is especially what's interesting in cancer, right? SEER. SEER, I think most of you heard or use SEER. SEER is at the national level, but SEER is not the only data source you can use, right? You have SEER, you have NCI, ACS, USCS, and then there's some dedicated websites that focus on certain diseases, right? For example, there's Leukemia Lymphoma Society, and you've got good stats and some data as well. And then interestingly, we found that if you go to cancer.gov, or you got, both of them exist by the way, cancer.gov and cancer.org, they basically pool data from SEER, NCI, and ACS. So when you type on the website, you go, and then they basically bring you that. So we're not really counting cancer.org, so we're looking at the other 5 guys there. So I'll give you a quick sense. So the SEER data would give you the registries, kind of data they get from the registries. It covers about half of the population of the country, right? That's at the national level. And so examples of data, you have the breakup by ethnic race, ethnicity, by the stage of the cancer, right? And then by cancer type. So here we're focusing on the triple negative breast cancer, right? And then you get the breakout, localized, regional, and it becomes metastatic and all that, right? These type of things. So this is good data that you have, right? Another one which we like is USCS, right? This is another interesting source with 37 million cancer cases, depending on how you want to use it. And the big advantage, it goes down, it's lower in terms of granularity for geography. And here's an example. This is also about breast cancer. You get all the counties, and then you get the incidence, and also the population, right? So you have, in this case, it age adjusted, meaning that you can compare 2 different geographies without caring about the age distribution. It's already accounted for. Then you can say, oh, this one has more, or this one has less, which is pretty convenient depending on the analysis you want to do. And then we have the NCI. This is a go-to source for all kinds of information on cancer. I mean, more than what you want, most probably. So here is some 2 million new cases of cancer in the US, how many people died. Those are kind of general level, and the breakup by the biggest types of cancer, right? Mortality about men, women, breakup by, and so on. So those are kind of info you can get from there. Incidence at the national ACS, breast cancer incidence national, and this is the kind of information that you can get, okay? And then there are kind of specialized kind of places for certain diseases, right? Which is not kind of government-based, so LLS, that's not government-based, kind of non-profit organization that has this thing. And they provide information on leukemia, lymphoma, and it's super detailed. I mean, you'll go and you get 20 different kinds of leukemia and so on. Probably more than what you want, but it's super rich information. Any comment here before I switch from the cancer? Yeah, go ahead.
Yeah, JP, quick question. I know in the industry, there are what I call more data aggregator, or they leverage this data, for example, Kantar and some other. Can you comment about the pros and the cons to go to the source and or leverage existing summary from another data supplier for this space?
I think the big pro if you use the Kantar is that you get someone you can talk to to answer the question and then to orient you and maybe help you hand holder. And but oftentimes you don't really know if that's the data source that you need, right? If you really paid for that, then we'll find a need for you because you already paid, you have to justify why you paid, right? So then, and then it's not clear what is the extent of what they would go, because it's not in their natural interest to go and point to data sources which are absolutely free and sometimes can be of very good quality. So there may be sometimes some conflict of interest. So yeah, but if you're using them, you can get the advice on the data sources and show them some data and say, what do you think?
Have you compared, the data?
We've used Kantar data for projects, of course.
Okay.
And this one, those are data sources that are super trustworthy. I mean, the government spends so much money on that stuff. And this is high quality data. And oftentimes you see, for example, Kantar, these stuff that we saw, like what drugs are used in line 1, line 2, line 3 that we were. I mean, they cover different questions.
Yeah.
So I think a direct comparison is not super fair. But I would certainly look at what's available, not only through the lens of the commercial vendors that you use. You had a question, I think.
Yeah, I was just curious on some of these are generally a Medicare, Medicaid population that feeds these free data sources, or is this commercial?
Actually, I'm not going to say a few words about this as Medicare, but there is a whole coalition of each which is being independent. So you get Medicare, commercial, and all that stuff. So it's not really Medicare. Okay. So by the way, I think because the next one is Medicaid. Well, we have dual eligibles, right? So that may be, you may well be right, that we counted there, but that's not very kind of dual eligible. And so this is data reported at the state level. And as I was mentioning before, we used to have HORS in the state, and now you have all the stuff on Stop Shop. And so this is the fee-for-service part, right? So there's the commercially managed, the managed Medicaid, as you know, and this one focuses on the FFS. And by the way, when you look at the HORS in the PLD data, they are essentially around the FFS, because receive claims on the commercial side that are either purely commercial or managed on behalf of Medicare, Medicaid, and so on. So they have kind of a, not perfect, but kind of a good read on the Medicaid side, but managed commercially.
Yeah.
But the pure Medicaid, normally it's not that good, right? So this is the kind of split between FFS and managed Medicaid, 60% FFS, 40% managed Medicaid, there's some dual eligible and so on. And let me give you a sense of what the data looks like. So this is the data, got 15 fits in there, right? You get the FFS, the state, it would go at the NDC level. So if you have a drug that has like 100 NDCs, and then there's something called suppression. So this suppression happens very rarely here, but if you have less than, you have 10 patients or less, they would suppress the data. And the two cases, the one case, they tell you they suppress the data, star, and the other one, they suppress it, you don't see anything. But for us, it's a big difference as data analysts. You like it to say, oh, I'm suppressing the data because you know what they're suppressing. The other one, you don't know what they're suppressing, right? They don't even tell you what they do. And so that's kind of of interest here. You get the suppression use, so they tell you. We're not hiding any information from you, right? And then here the unit reverse, number of prescription, total amount, Medicaid amount, and non-Medicaid, Medicaid and non-Medicaid, right? So that's interesting data. And then, so that was the big question. Remember the free question that we started off with, completeness. What are the cores? We have the numerator, but we don't have the denominator. Second one is granularity, and third one is new perspective. So I'll hand over to Shanmugam, who's going to talk to you about the enhancement.
Yeah. Thank you, JP. Hello, everybody. This is Shanmugam. I work with JP. So I'd like to start with this short story because I know I stay in Chicago, and coming to the conference, it's very easy drive, right? 94 is really easy from Chicago as well. So it was a short drive, but then just in case, I put on Google Maps just to actually save one time, right? And for both days, it took me to 2 different routes. So the objective, and it was free to use, and that's exactly the point of why we are so excited to use these free data sources. And CMS has been chucking out these data sources like crazy in the last 4 or 5 years, and we kept track of most of them, so hence the point. So we'd like to go into how we can enhance the data, and I have 4 interesting questions to address that. And like JP was mentioning, the fee-for-service part is always underrepresented in PLD, right? So they spend the big bucks in Part C, Medicare Advantage, But then, how can we compensate that in the hospitals, right? A hospital also, JP was saying that it's only 10 to 15%. So we found data sources that can enhance the inpatient and the outpatient using the DRG codes, diagnosis-related group codes, and the APC, which is the ambulatory payment classification. And then we'll move into to addresses Kevin's question, right? So to look at not just the Medicare piece, but these data sources, AHRQ, HCUP, they actually talk about all payers, and they cover a good chunk of the actual capture all the hospitals, I believe. But the data is a little old, so with the sense of caveat. So this is actually an example of the inpatient activity. So, and we took Evanston Hospital, which is right next door, and for the 2022 year data, so these are the list of DRG codes, and you can look at renal failure, acute myocardial infarction, and we rank order based on discharges. So we took the top 20, and then we break down by average submitted charge. So if you want to take a look at the total volume, you can multiply, right? Very simple. And the average total payment and average Medicare payment. So there's not much difference between the two, but Medicare being one of the biggest payers. So, and then we take a look at the hospital outpatient, which is the APC codes. The structure is a little different. I'll point out, we took the same hospital, but the year also is 2022. And there we saw discharges, right? So here we have beneficiaries and services. And we have submitted charge, Medicare allowed amount. They don't have total payment, but Medicare payment. So, yeah, so then I'll kind of move on. So now we're kind of zooming out of the hospital space into all payers, right? Actually, from the Medicare to all payers. So, AHRQ has 4 different main data sets. They have 7 in total, but some of them are in portal, so we took a look at the top 4, which actually came to our list. And then they drill down from the nation to the state and to further below, like emergency department. But all 3 of them have different cuts of data. They have for all stays, hospital, and then they have diagnosis and procedure. So I hope I'm not confusing, but there's a lot of options, but we just took a few to kind of highlight what all variables they have access, they publish. So within the national inpatient sample, we call it the NIS, they're beautifully categorized into ENT, right? And then female reproductive system, GIS, urinary, and then lymphoma, hepatitis related, which is, and they give the number of discharges. And this is actually a list of like 191 products, procedures, sorry. And we just took the top 35, and then we go into the state. So we go one level deeper from the national to the state. And here we looked at all states. Instead of just diagnosis and procedure, if you take all states, then we can see the expected payer as well. So it was Keith's question on they break down Medicare, Medicaid at each state level. So we wish this a little more deeper, but nevertheless it was good. And we go into the kids population. So anyone below 21 years or younger, where there are registries who submit this to AHRQ, and the number of states rose from 22 to 48, which is actually the most recent set. I know 2021 is the most recent set. This is a little dated compared to the other two. I think they updated a little slower. But here we saw diagnosis, we saw payer, now we're seeing we saw procedures, and then we saw expected payer, and then now it's diagnosis. They have like 402 diagnoses, so this adds some, oh yeah, go ahead.
One question I've got, so let's say for example you have a list of either procedure codes of interest or ICD-10 codes of interest, and you want to query this to see, hey, what's this hospital bill, right? So this teaching institution or whatever it is. So if I have that list, I could link up to these tables and find that out.
Yeah, actually that's a good question. And so we'll have to do the mapping ourselves. We can't input ICD, but based on the ICD classification, we can actually they have refined it. So there's 2 levels too. So within the diagnosis, but yeah, you can combine and take the ICD and then map it to specific disease state. Yeah, with diagnosis and procedure. Okay. Right.
So there's something called the on the DRG. There's a bridge that matches the DRG, what we call the MDC, the major diagnosis code that maps into the ICD code. So by using the previous database on the Medicare, say inpatient, the DRG, you can map into the ICD code through a couple of hubs, and then you can look at your database, say from EMR or PLD data at the hospital level, and you can link to the larger DRG picture. In addition, there's always two things, right? There's a profile and how many beds you have, and that kind of stuff. There's the ownership and teaching.
Well, I'm looking for this treatment that I'm interested in.
Yeah. So
Like-
let me give you an example, Scott. So
But
if you
the
take
answer is yes.
Yeah.
if you take prostate cancer, right? So I would actually start from here, which is the male reproductive system, right? I think there might be drill downs here. Yeah, that's how I kind of. If there's another disease state, you can zoom in on those particular.
Then the other one we could use is the I think the other part A, the one that we talked about. You have
Oh.
directly the list with the DRG codes, and you can link it with the
Right,
other MDC.
right.
That's
Yeah.
what I'm saying.
That's easier too.
Yeah.
Yeah, good point. Yes.
So you guys ever use Dartmouth Atlas?
Hmm?
The Dartmouth?
Yeah.
database?
Yeah, yeah.
Okay, I wasn't sure.
Right, so the kids I know, this is for diagnosis, they have the aggregate hospital charges for 402 diagnoses and 191 procedures. And emergency data, this is the ER visit, so which is even better. So in the ER visits, they classify into two groups. One is treat and release, which is same day and then release it, so that will be an outpatient. But if it's this, if the ER visit leads to a hospital admission, then they track it as well. So those are the two different cuts. And we can look at the patient population, how they break out by race and ethnicity, and have the estimate and also the confidence interval. So, and this is available for all of them, all states, just showed Illinois. Any questions in this data set? Okay. Yeah, or I'll take them in the end too. So now we actually go into, okay, we looked at hospitals. So is there a possibility to go deeper into physician level, right? And the answer is yes. With there are two different. I think these are the biggest data sets, maybe outside of FDA drug book. But yeah, so the Part B and D they updated really well, and the Part B actually captures the fee-for-service part within the Medicare patients, and the Part D just the PDP piece. So they don't track the Medicare Advantage. And within the Part D, every 1 person in 4 that are Medicare patients actually don't have any drug coverage, which is the 77% actually of the Medicare beneficiaries have the PDP program. So, and then we'll go through the Part D. Yeah, so in terms of time, I'll kind of make it fast. So, yeah, and this is a synopsis. Let's go to the example directly. So here's a physician, and then we have the HCPCS code, and we listed out the top HCPCS code as well. And the Part D is similar, but for RXs, right? So, and the most recent data that's available is 2022. So here's a list of the field names, and you can see the drug name. They don't have NDC, but just the drug names, the claims, and the number of fills they supply. So these are the list of drugs, the top 20. This physician specialty. I'll skip this part since we have just 5 minutes. Okay, so the KO identification.
I have a question about
Sure.
positional data.
Yeah.
Are there any limitations to how you use that data?
I'll cover that. Have a proposal.
Okay.
Right. Yeah.
Thank you.
Thank you. So, in terms of KO identification, we actually can use these data sets, referral data set and ExpertScape. So, referral actually is a very simple data set. From an NPI to NPI. And the interesting part is you can use the NPI. It doesn't mean just physicians. It could be dialysis centers, infusion clinics, right? So you can dotted line make the connection between physician to what practices or what infusion centers is having relation with, and Expertscape. This is actually a new one that we found. Thanks, shout out to Melis who actually found this in our team. And she found that how the Expertscape actually pulls in data from PubMed for the last 10 years, and then lists out based on the any therapy lung neoplasm experts, and we can look at these guys who might be the potential PIs for running trials. We're actually helping a client with a project on that. And if you pick a specific doctor and see what affiliation he's been connected with, right? This particular Raphael Rosell actually started in 2015 from University of Nebraska, and then he had a bunch of miscellaneous institutions. And then in Pittsburgh, I know Allegheny is in Pittsburgh. So that's how, I think it's a good timeline that actually shows the affiliation now. The final question for this section would be the lookalike models. So we're always trying to actually combine PLD at the physician level using tokenization, right? So we thought it was a little expensive, but this one actually combines it at the geographical level. And we feel it's you'll save a lot of money, and it's easy to run based on geography. I know it might not be as accurate as the patient level matching. So are you
saying that you could take, let's say, patients who take drug X, right, and connect their social and economic data versus patients who take drug Y and see if there's a difference in the patient types or the...
Right, so we connect them at the geographical level, right, Scott? So we'll see, okay, if there's a lot of prescription in the cancer belt, then is there a geographical bias to it? And we can tap into a little more granular, but I would say granular, but more geographical level. But it won't be a one-to-one mapping. Okay. So yeah, we can go the county, census tract, block, yeah, so even much deeper if need be. So yeah, so the SDOH, I know I'll go quickly. So not just the government, even the universities actually release these data where they track the policies to health factors and outcome. And this is a sample data we took for Cook County, and the level of detail is amazing, right? So, and this is actually, we started with the biggest one. I think this has 83 variables, but we just listed a few. And the second one is places. Actually, they launched places with just the cities. And now they've expanded to county, census tract, and zip code. They actually break it out by health outcomes, disability prevention, risk factors. I think the most interesting one is the health outcomes. And we broke down health outcomes by the disease state as well, and by zip. So, and then the EPH, the environmental conditions that lead to a specific disease. So we have like radon and tornadoes and drought. And we zoomed in on heart disease and stroke to show a quick dashboard. It's a dashboard, it's not a downloadable file, so a little inconvenient there. But then you can track the metrics. I think there are like 30 variables, right, that I was mentioning, yeah. So, and finally the social vulnerability index. They derive the data from American Community Survey just to prepare for disasters. Who need help in which community before, during, and after disasters. So they bucket into 4 different sections: unemployed, which is socio-economic status, then the household type, whether it's a single parent household, English language proficiency, racial status, and also the housing. Do they have a mobile home and things like that? So here's an example. I know I'm going too fast, but yeah. Yes. So I know I had just 5 minutes, so yes. Over to JP.
Thank you, Shankar. Okay. So the last part we covered completeness, enhancement that Shankar covered, and there's a lot of things here. As you can see, there are a lot of data sources. And then so I'll cover a couple of them on the human perspective and analytics. Okay. So one of the questions that we ask is, okay, give me a little more on that. So one of the questions we ask is, we don't have a good thing like SOV, share of voice, the activity of the reps. We know the activity of our reps, but we don't have a good read on the activity of the reps in the country. And so one thing that we can do is to use Sunshine Act. And oftentimes when the reps is a doctor, you pay for the pizza. So there would be, if it's more than $10 the pizza, I think the pizza was more than $10, then it will appear, right? So it means that the Sunshine Act is a way for you to compute SOV, because it's tied to the actual drug and the company, right? So in the Sunshine Act, there are 4 parts to it. The 2 parts that we find interesting is when we go to general research. And the research would be funding that the company, the manufacturer would decide to buy some stuff from the doctor. And that's, some people say, oh, it's not possible, but you check the data, it's done. So you can also see the nature of the transaction. And some of the things that you can do when you're looking for KOL for a new drug is what we call the allegiance index. So you can differentiate a doctor that takes money from anyone, or the doctor that takes money only from one manufacturer, right? And there's a big difference because this person is already like sold to in bed with someone. It's more difficult to displace than someone like the butterfly who take money from anything that moves, right? So this is kind of interesting database. I'm sure that this is probably the most well-known, I would say, public domain data in this space, is Sunshine Act. And there are many uses. It depends on how creative or imaginative you are. Another one that's for forecasting that's very relevant is obviously clinical trials. And clinical trials, there's a big one like CTMS Sightline. There's a bunch of them. I can put that there. But this one, what it does, it tells you about the clinical trials that are happening and who's the PI, right, the principal investigator. And very interestingly, just in case you didn't know that, it would list all the institutions and the city-state zip of the sites that are running the study. And some of them, it's huge, really, really big, but you've got the whole list. And so it gives you a good sense of which drugs are big and which drugs are less big, right? So we looked at the sponsorship. It could be private, you have enough money, you want to fund your own drug, or it's a university, or it's industry. So this one focuses on the industry, and we're looking at 30,000 studies that are funded by the industry, broken out by phase, right? Phase 1, phase 2, 1, 3, 4. And it basically tells you the status. Are they still recruiting? Is it withdrawn? You know, what's the status of the clinical trial? And here's an example. This is one example of a clinical trial happening. And you can see here Mayo Clinic, Phoenix, and you get all this stuff here, right? All the city-states, just in case you didn't know that was a clinical trial. And you also have the name of the drug, and if you want to use ChatGPT, you can get a good sense of the direction where the study, what they're trying to do, right? So that's kind of cool. If you look here, study, non-recruiting, what they're doing here, phase 3 interventional, completion date, and so on. Very cool database. So quick recap, and I'll close Scott. Recap of the 26 data gems. Here's a little picture of it, right? So what we have here is we have the activity databases and we have the profile. So this is the telephone book, the profile, and this is the activity, and which is what's going on. So this tends to be dynamic, and this one tends to be static. And obviously between the two, you have some kind of hybrids, and you have some stats. So if you kind of try to make sense of it, you can find kind of what are they talking about. And you can say, oh, about the payer, about the geography, about the hospital, about the account, about the physician. That's an actual way of breaking down kind of the what's the topic of the conversation. So if you look at the payer, the geography, we have what Trump covered at the state level. I covered the state levels, Medicaid, drugs, and those are at the hospital level, and at the physician level, the Medicare. So it's the actual name and PI of the physician, right? I mean, they apply BD referrals, clinical trials. You have Sunshine Act here. You have the cancer stats that we talked about. Formulary payer, we didn't talk about that. I've got a few that are white, and those guys, we didn't need to use them with 7 questions that we just answered here. But they're super relevant if you want to do payer analytics. You want to do anything that has to do with affiliation, hospital affiliation, group practice affiliation, dotted line affiliation between the injection infusion center, the doctor, all kinds of stuff that you do, right?
Yeah.
So they come in super handy,
Yeah,
right?
shout out to CareSet actually for talking to CMS and releasing the referral data.
Yeah. So, and the hospital directory. So the 7 questions, those are the questions, just a recap of the questions that we covered. Take home message for you, Karen, I haven't forgotten you. Completeness, enhancement are the 3 concerns that we always have when we do analysis. Many are in the public domain, and we have what we call the paradox of the free, right? Kind of Econ 101, surprise. And the kind of challenges that we have, that's for you, Karen. First one is the data kind of dated. Some of them were like 2022. Okay, so if you're launching a product that may not be the best way to enhance your data, you need to understand that this is data. But then you cannot complain too much, this is free. Right? The second one is the business of suppression. So when you look at the denominator, you need to understand that the denominator may be missing something itself. And one thing that you want to appraise is what is missing in your yardstick that you're measuring, right? And Sean Graham didn't cover it, but he has a slide that shows some tricks that we developed to estimate how much we're missing. Because if they tell you 10 patients or less, and you have a bunch of records, so you can put an upper bound on it by multiplying the number of records with 10. And then you can take an average, say you go like 5. You can put like a realistic bound on how much you're missing. And so it gives you, your ruler says like this, but you do it maybe between here and here. So your denominator is not too bad, right? And then the other thing that's happening is that you have changes in formatting and availability. And it's something that changes all the time, right? The format change in Sunshine Act became available in 2014 based on 2012 data. Before that, it didn't exist, right? You have reference data used to be available in CMS, and now you have to go through CareSet and stuff up to get that kind of data, or you have some other routes to do that. Physician affiliation, now they split the physician affiliation into affiliation to a group practice and affiliation to a hospital. And there are kind of caveats in data that you need to be wary of. So our recommendation is, keep on digging, and don't forget that you may be looking at the diamond in the rough. So you may have to polish the diamond a little bit before. So this is kind of a chart that we found very helpful. It's the HHS, and it has the different departments of the HHS, and you can get the from things like HRSA, CMS, CDC, FDA, and so on. Interestingly, there's one that's not in there. Can you guess which one is not there?
Price transparency.
Huh?
The price transparency.
Yeah, and what else? DEA. DEA is not there. That the Department of Justice. But anyways, that's a very good place to, if you want to dig. And we've been digging, and here's our chief digger. And I think it's very helpful for us to know about things that are available to us. And because of the paradox of the free, we don't know about it. With that, any question?
Is there any reason why you didn't include the price transparency data that's coming out?
What's that?
Is there any reason why you didn't include the price transparency?
Yeah, so it has to do with the 7 questions that we led with. So should we have an 8th question about the pricing and why are we, the 10 drugs that are, and the price going to decrease as of 2025, the 10 selected drugs, Medicare drugs, as you know, right? So had we included and talk about, the changes in the stuff, Medicare design and all that stuff, right? But we didn't want to overwhelm the stuff, so we thought that those 7 questions were the most natural questions that anyone would have, and that's okay. Anything you can? Yes, sir.
Shanmugam, you said that CMS released its affiliation data. Tell me
Yes.
more about that.
Yeah, I'd love to. So, yes. So initially, it used to be a combined data set, right? And both hospital affiliation and group practice. Now they separated into 2. One is called a facility affiliation, where they have the entry of the physician, and then they have the hospital, dialysis center, all the types, right? Inpatient rehab, I think home hospice and nursing home, right? Home health. Right, so that's one style. And the other one that they still own is that it's called a physician compare, where they have the physician name and then they list all the group practice that they're affiliated to. And also how many people are within that group practice. It's insane, right?
Yeah. Because you're used to buying one key, so you don't know about that.
And can anyone take a guess how often
Each
they
course
update it?
data.
How often do they update it? Do you guys know? Every 2 weeks. Okay. The last one was launched, I think updated September 28th. It's like, wow.
Yeah.
So cool, right?
Those are things that you don't know.
Yeah.
Okay, guys, thank you.
Thank you.